Welcome everyone to today's webinar, PCI in the ASC, Pursuing the Shift of Cardiovascular Procedures to the Outpatient Setting. I am Angie Stewart with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Before I turn the floor over to our wonderful presenters, I do want to briefly introduce our sponsor. Cardinal Health is an integrated healthcare services and products company providing customized solutions for hospitals, pharmacies, ambulatory surgery centers, and office-based labs. They have a robust portfolio of products and services to help you deliver exceptional and cost-effective patient care, as well as a dedicated team of experienced ambulatory surgery center and office-based lab representatives and clinicians that understand the unique supply chain needs of your OBL or ASC. Together with Cordis, a worldwide leader in the development and manufacturing of interventional vascular technology, they're uniquely able to serve outpatient cardiovascular centers as a single source vendor for all of your devices and supplies and can help you find new ways to improve efficiency and save money. I would now like to welcome the moderator of today's webinar, Tim Gruber. Tim is a corporate account director at Cordis and has 27 years of commercial experience in the medical device industry. During his career, he has had a focus on the non-acute side of care and has a passion to see the OBL and PCI in the ASC models be successful. Tim, I will now turn the floor over to you.
Hi, good afternoon, everyone. Thank you for joining. And as Angie said, I'm Tim Gruber, and I'll be moderating our discussion today. Before I introduce our speakers, I'd like to quickly review today's agenda. We will begin today's webinar by reviewing the current landscape for coronary intervention in the ASC space, and we will then learn how to build a business case and a clinical case for PCI in the ASC and wrap up with industry factors influencing adoption. And with that, I'm excited to introduce today's speakers. With us, we have Dr. Matthew Comstock, an interventional cardiologist based in Tulsa, Oklahoma, and Jared Leger, CEO of Arise Vascular. Dr. Comstock and Jared, welcome to the webinar, and thank you for joining us. Before we start with discussion, Dr. Comstock, can you please share with us your background?
Hello. Thank you to Becker's Healthcare for having us on this webinar. Thank you everyone else for joining us today. We have a lot of great topics to cover. As Tim mentioned, I am a board-certified interventional cardiologist and owner of Tulsa Cardiovascular Center for Excellence. I attended medical school at Oklahoma State University, followed by internal medicine residency at University of Oklahoma. And then I completed general and interventional cardiology fellowship back at Oklahoma State University, where I was also the chief fellow. For the first few years after completing fellowship, I was a hospital-employed physician and averaged over 1,000 invasive cases per year with greater than 500 interventions and 100 implants annually. I performed device implants, high-risk PCI with hemodynamic support devices, complex peripheral and venous interventions. I was frequently producing in the 90th percentile for RVUs a month and placed in the region's top 5 users of Impella nephrectomy devices. I was inspired by some of the landmark achievements in the advancement of peripheral arterial disease and possessed with an entrepreneurial American spirit and a strong desire for autonomy. I left hospital employment and entered independent private practice in 2019, where we created the Tulsa Cardiovascular Center for Excellence and established the first private practice outpatient office-based lab in Tulsa, Oklahoma, dedicated to peripheral arterial disease, limb salvage, and amputation prevention.
Thank you, Dr. Comstock. You've certainly been busy. Jared, can you please share your background?
Yes. Hi there. Thank you all for joining us. Thank you, Tim and Cardinal and Becker's for having us. My name is Jared Leger. I'm a licensed registered nurse by training, but I've spent most of my career starting healthcare companies, and I've served largely in an executive type role, but I do love my clinical roots. I have owned and operated ASCs for over 15 years. Currently serve as the CEO of Arise Vascular, based out of Austin, Texas. Arise Vascular partners with physicians to own and operate their own outpatient cath labs, as well as cardiovascular ASCs. We also provide management services as well as billing services to these facilities. We have opened 4 outpatient labs this year. Our newest facility, which is a single specialty cardiovascular ASC, will open in just a few months. We are hoping to open 2 more facilities this year.
That's great. You both certainly bring a lot of experience, even in a market that's just developing. So Jared, can you share with us what triggered the development of coronary intervention ambulatory surgery centers?
Yes, Tim. I think the easiest answer is the advancement in the outpatient technology over the past few years. There are many clinical technological advances that have let outpatient PCI move to the ASC setting safely. Dr. Comstock will go over some of these advancements later on. Just like we have seen advances in other outpatient specialties like the orthopedic industry, neuro, and pain management industry move successfully from the hospital setting to the ASC setting, cardiology is the next natural specialty to make this move. CMS has been talking about and forecasting the PCI procedures to be added to the ASC approved list for many years. In its final rule, CMS comments that after looking at clinical safety data, as well as receiving clinical advisor input, CMS then determined PCI could be safely performed in the ASC setting. I think it's also important to note that both the American College of Cardiology, the ACC, and the Society for Cardiovascular Angiography and Interventions, SCAI, have both written letters that support the addition of PCI in the ASC setting. Another driving factor to bring up is the cost savings opportunity to the Medicare system as well as the other commercial payers when looking at moving PCI into the ASC setting. As we all know, CMS is always looking for ways to safely cut cost. The average reimbursement rate for the 2 most common PCI CPT codes in the hospital outpatient setting, or HOPD setting, is around $12,000 per case. Those same CPT codes in the ASC setting would reimburse an average of $6,100 per case. This results in roughly a $6,000 savings per case if PCI is performed in an ASC setting as compared to a hospital. 700,000 Medicare PCI procedures are performed each year. CMS first estimated that by moving 5% of the PCI procedures from the HOPD setting into an ASC setting, it would anticipate Medicare spending to be saved by roughly $15 million per year and save out-of-pocket costs for Medicare patients by roughly $3 million per year in 2020 alone. CMS later updated these figures to state an expected savings of $20 million per year to the Medicare system and $5 million per year savings to Medicare patients' out-of-pocket cost. However, we've seen other publications that have cited that if Medicare was able to successfully move 20% of the 2 most common PCI CPT codes from the hospital setting to the ASC setting, the savings could be around $811 million per year. That's a very large savings opportunity for the Medicare system. The opportunity that this new rule has created for the ASC industry is enormous. Our internal projections, not backed by scientific data, but rather by polling our existing cardiologists, show that as many as 20% of the existing hospital-performed PCI cases could potentially be moved to the ASC setting safely. At roughly $6,000 per case, this has opened up a potential $840 million market for the ASC industry, and this is just Medicare business alone. Another driving factor on the push of PCI to the ASC setting is the patient support. We all know patients love the ASC setting. It's generally a lower cost setting for them. The ASC patients are not exposed to acutely ill patients while in the facility. Parking is easier. The admission and discharge process are oftentimes easier when you compare the ASC to a hospital. We also see that the doctors are also pushing for the ASC setting. All the Arise facilities are physician-owned. This means that our physicians are more in control of the facility as compared to a big hospital. The ASC is their own place with a culture of doctor-led decision-making, and the doctor has a voice when it comes to their own facility. They're oftentimes able to handpick their own staff members. They can choose which vendors are used, which type of equipment is purchased, and have more of a say in what goes on day to day. As a physician owner of your own facility, you also have a lot more control of your own schedule as compared to a hospital cath lab. Dr. Comstock can probably attest to this, but oftentimes cases are bumped due to a STEMI coming in or other reasons that a case may get bumped. And also, hospital cath lab turnover times are oftentimes longer than what you see in an ASC setting. And then lastly, I would say that there's also an economic advantage to the physician if they have an ownership interest in the ASC. They're able to financially benefit from the profits of the ASC, and the doctor is now invested in the economic and reputational success of their own facility. We are of the thought that healthcare was always intended to be run by physicians, and if the physician is successful, then we're all successful.
So, Jared, this is a relatively new market dynamic as it just started with CMS approval effective 1 January of this year. Is that right?
That's right, Tim. So in 2019, CMS allowed for diagnostic coronary angiography only, so not intervention, not PCI. However, the total reimbursement rate from Medicare and even the other payers was so low that it made very little profit margin opportunity in the ASC setting to just do the angiography cases. So many ASCs and cardiologists did not adopt the ASC place of service. Oftentimes, when choosing which type of facility to open, many cardiologists chose an OBL or an office-based setting and planned to move to an ASC in the future when PCI and the reimbursement trends became more widely adopted by Medicare and the other payers. However, we do know many ASCs have been able to successfully get in-network agreements with the private payers to pay for PCI even prior to the 2020 edition. Oftentimes, payers are able to recognize the cost savings opportunity, safety, and the benefit to their patients for the ASC PCI procedures.
So in what markets do you see the development of cardiac cath ASCs occurring?
That's a great question. So it's rapidly evolving, but I would say from just our talking to folks and being in the industry, we mainly see the single specialty cardiovascular ASCs opening in markets where there's enough independent cardiologists to support volume to the ASC and keep it busy. A prime example of that would be a large independent cardiology practice. We also see it in markets where there's 5 or so independent cardiologists who can partner together in the ASC, sort of like you see in the orthopedic industry, where they have their own private practices, but then all come together to joint venture the ASC. One point to kind of mention is that the ASC is very expensive to build out, equip, and operate. And if the ASC sits dormant, it's a recipe for financial failure. We also see many outpatient cath labs, also known as office-based labs or OBLs, who've been doing non-coronary procedures or non-cardiac procedures like the PAD procedures, that's the peripheral artery disease procedures, and vein procedures. Some of these OBLs then want to add ASC to be able to capture their PCI business. This is where we oftentimes see the hybrid model work well. This is where the facility operates as an OBL on certain days and an ASC on other days. There are many regulatory hurdles to be aware of when choosing this hybrid ASC model. Very complicated, just to say the least. You must have preset OBL versus ASC days. You can't commingle or share the space at the same time. You can't commingle staff or medications. A separate medical record is needed for the OBL and the ASC, and many more rules to follow. Prior to venturing into the ASC hybrid model space, we always recommend engaging a healthcare attorney, certainly like Scott Becker's group who organized this call today, who have experience in setting up the hybrid ASC model. We're also seeing some multi-specialty ASCs and hospital joint ventured ASCs who are looking to add the cardiology service line to their already operational ASC. We see some of them offering ownership interest in the ASC to the incoming cardiologist. There are many challenges with this model. You must have the space for a large fixed-base imaging system. You must have a dedicated room for the cath lab that can't be easily converted to an operating room for the other specialties on non-cath lab days. Not to mention the fact that the equipment and the setup is very costly. And then lastly, if you're considering bringing in an incoming cardiologist to an already cash flowing ASC or operational ASC, what is the price for these shares? How will the incoming cardiologists, want to pay this price? Will they want to pay it? Oftentimes, if the ASC is already cash flow positive and paying distributions, the shares must be sold at fair market value. Typically, this fair market value is based upon a multiple of cash flow. Cardiologists sometimes aren't used to seeing buy-ins into an ASC, and they oftentimes feel like it's expensive to buy into an already cash flowed ASC. These are all questions and issues that must be navigated prior to exploring adding a cardiologist to your existing ASC.
Thank you. I know this is an even more recent dynamic, but do you see the COVID-19 epidemic influencing the market expansion?
Great question. I would say that the roles of the ASCs in the COVID-19 crisis are quickly evolving. Most of the procedures that are performed in an ASC are considered to be an elective procedure, and as a result, during the COVID-19 crisis, there was a restriction on these procedures that were considered to be elective. And we for sure saw a decrease in patient volume and our revenue for, I would say, about 8 weeks. We also saw decreased clinic volume, which means less facility volume, as you guys know. And for a while there, things certainly looked bleak, at least for my facilities. However, on a very positive note, I'm happy to say that as of really last week and kind of the week prior and certainly this week, we're starting to see clinic volumes get picked back up, and our facility volumes are also increasing. Also, I want to mention that the governmental support and aid offered during the COVID-19 crisis was really helpful to us. Our facilities all received PPP funds, and most of them received some type of HHS grant funding. I must say, without this assistance, our smaller facilities and even our larger ones would not have made it without major layoffs of staff. And we tried very hard, and we were able to keep everyone paid, even during minimal case volume days. I know other colleagues in our industry who were also helped out by loan payment deferrals from the SBA and other private lenders. And let's also talk about patients during the COVID era. Patients are fearful of exposure to COVID-19, and our patients are oftentimes seeking care outside of the hospital. ASCs can provide a great alternative to a hospital. Dr. Comstock can comment more on this, but he and I were just talking about how many of his very own clinic patients are afraid to go to the hospital, even for emergency conditions like stroke and chest pain. So overall, from an investment perspective, we believe the long-term outlook is positive for ASCs. There are also many other governmental programs that were temporarily developed for the COVID-19 pandemic. One of them is the Hospital Without Walls initiative, whereby an ASC can become a hospital with a relatively simple attestation process. We also saw temporary waivers that were issued to Stark and anti-kickback statutes and other safe harbors. One point of note is that our legal counsel has advised us to be cautious and aware, because we do see some risk of CMS rolling back these initiatives once the COVID-19 crisis is over.
It's interesting. Certainly the COVID-19 pandemic is a terrible thing, but it's encouraging to see that perhaps something positive might come out of it for the ASC market. So we know the market drivers and potentially an adoption pathway by region or state, and although that's evolving quickly, let's talk with Dr. Comstock and get a physician and entrepreneur's perspective. Dr. Comstock, before sharing about your facility, as a physician, can you talk about the evolution of coronary intervention and why you feel it can be safely conducted in a non-acute setting?
Sure thing, Tim. So coronary intervention has consistently evolved at a very rapid pace. We have been performing same-day discharge post-PCI within the hospital outpatient setting for the last decade. There have been multiple factors that have contributed to successful same-day discharge programs, most importantly, proper patient selection, access site selection, such as the radial artery versus femoral artery, reduced equipment size, and bleeding avoidance strategies, among others. In 2018, SCAI released a census document stating that advances in practice and technologies have made discharge following PCI demonstratively safe when milestones of clinical stability, procedural success, and process measures have been achieved. So earlier this month, on May 14th, 2020, SCAI also issued a position statement regarding outpatient PCI. In appropriately selected patients for outpatient PCI, clinical outcomes for same-day discharge or routine overnight observations are comparable without any difference in short-term or long-term adverse events. Please keep in mind that the document advises that the only patients who are considered appropriate for same-day discharge should be considered for intervention in the ASC. So this is great progress, but let's review a little bit of the clinical data that has made this transition to PCI in the ASC possible. We have multiple randomized clinical trials comparing outcomes between same-day discharge and overnight observation with no significant differences in major adverse cardiac events, or MACE. One of the largest observational studies regarding same-day discharge came from the CAF PCI registry, involving over 100,000 patients 65 years or older who underwent elective PCI, which showed the primary outcome of 30-day death or rehospitalization were similar between patients discharged home the same day versus those who were observed overnight. Furthermore, meta-analyses have been performed to assess differences between same-day discharge and overnight observation from randomized trials alone and randomized trials plus observational studies. Each of these has demonstrated no significant difference in acute or medium-term mortality, myocardial infarction, or MACE. Length of stay following PCI shows no significant increase in adverse events for ad hoc PCI with same-day discharge. We have access to numerous studies from the United States, United Kingdom, and Canada, published in multiple journals, treating thousands of patients with results from 10-year data that show same-day discharge is safe and effective after ad hoc PCI with no increase in MACE. The most important aspect of successful PCI with same-day discharge is proper patient selection. So with such robust data showing that same-day discharge after PCI is safe and effective, is a natural evolution to bring this cost-saving and beneficial practice to the ASC setting. Based on a large volume of data we have and society position statements and guidelines to advocate such, it should be very apparent that same-day discharge for PCI is safe and effective in the ASC setting when performed with the appropriate patient selection. One of the most important and notable factors to mention in allowing the progression of outpatient PCI with same-day discharge to the ASC is the rapid advancement in technology regarding equipment size and availability, access site selection, and vascular closure devices. As the outer diameter of equipment utilized to perform PCI continues to become smaller, we have seen an approximately 16 to 25% reduction in the size of the access site. This leads to reduced bleeding complications and quicker ambulation time. Numerous studies have proven that radial artery access has given the ability for much earlier ambulation, reduced access site complications, with increased patient satisfaction, comfort, shorter recovery time, and decreased overall cost. Furthermore, radial access product lines continue to evolve to become more robust as this technique becomes more standardized and adopted across the United States. Cordis offers an excellent product for radial access called the Range Sheath that utilizes thin wall slender technology to further reduce the size of their arterial puncture. There have been significant advances made in femoral vascular closure devices, with studies proving reduction in bleeding complications and earlier ambulation. In addition, not only do we have the benefit of reduced equipment size with radial access, we also have the ability for more controlled hemostasis, reduction in bleeding complications, and earlier ambulation in the form of radial artery compression devices, such as the Cordis Cypher band for vascular hemostasis of the radial artery, or vascular femoral closure devices, such as the Cordis Minx extraarterial sealant. As you can see, we have a combination of reduced equipment size, radial artery access, hemostasis devices, and overwhelming clinical data to support the migration of outpatient PCI from the hospital setting to the ASC.
That's amazing. To think what you do is what used to be in futuristic movies. It's unbelievable. So please tell us about the Tulsa Cardiovascular Center of Excellence. Why did you choose to found such a facility?
So we are the only Tulsa-based interventional cardiology practice that specializes in peripheral vascular disease, limb salvage, and amputation prevention. I have a personal passion for peripheral interventions, both venous and arterial, in part due to the drastic improvement in quality of life you can bring the patient by restoring their ability to walk, heal from a chronic wound, or prevent an amputation. The excessive mortality rate associated with amputation is abhorrent, and we need to aggressively attempt to intervene and prevent these life-altering and highly devastating procedures from taking place unless absolutely medically necessary. Tulsa Cardiovascular Center of Excellence is the only private practice OBL in the Tulsa, Oklahoma market. This practice was founded to provide our patients with enhanced quality of care through utilization of state-of-the-art equipment, individualized patient treatment plans that lead to enhanced patient outcomes with a fraction of the cost. As a physician, we have an obligation to not harm our patients. To me, this means both medically and financially. If I can perform the same service or procedure without any negative impact on patient outcomes for a fraction of the cost to both the patient, the insurance company, the taxpayer, then I'm doing the right thing. This practice exists to put the patient first. As an interventional cardiologist, I still perform a high volume of percutaneous coronary intervention, Impella-supported PCI, device implants, and I have to read diagnostic imaging. Through my hospital affiliations and private practice partnerships, we're able to offer our patients a highly specialized cardiology practice that is not only guideline-directed, driven by industry best practices, but above all, patient-centric. If your group dynamic allows, an ASC OBL hybrid may be your preferred initial model. For me, the opportunity to start as an OBL or office-based lab was a reasonable way to begin influencing our local market dynamic to become more comfortable with outpatient percutaneous revascularization and same-day discharge procedures when performed outside of the hospital setting. There is a much lower cost barrier to entry, less regulatory requirements, etc. as an OBL than as an ASC. This gives you time to establish your workflow, staffing needs, policies, inventory, case costing, etc. Patients are extremely ecstatic about a robust private practice offering that includes outpatient imaging, revascularization, and same-day procedures. Heck, we even let our patients and their driver or family member order their post-procedure meal off of DoorDash on our dime. Each of our holding bays comes equipped with a 27-inch TV, Netflix, Amazon Prime, snacks, diet soda, DoorDash, etc. We excel at customer service. What more could a patient ask for? After they experience the convenience, ease of use, individualized care, significant cost savings, they typically prefer the outpatient setting over the hospital. I routinely have patients tell me that they only want the procedure or imaging performed if it can be done in my office. They do not wish to go to the hospital for blood work, imaging, procedures, etc., unless it's life-threatening. Once you create your own outpatient lab or surgery center and see the overwhelming positive response from your patients and their families, not to mention the increased professional growth, personal satisfaction, the biggest question you may find yourself asking as a physician is, why didn't I do this sooner? One other topic, though, I should touch on in regards to owning an OBL or ASC, it is an imperative to put the patient first and provide a strong self-policing strategy and internal audit to make sure that best practices are being adhered to and that you're providing patient-centric care. This requires the physician or physician group to be strict with self-regulation and utilization of appropriate use criteria, guideline-directed medical therapy, and adhering to society guidelines and position statements on treatment strategies and modalities.
So, Dr. Comstock, are you hearing from your peers that there's similar desires or interest in opening a facility?
So what I hear most frequently from my peers is astonishment at what we've been able to do and accomplish in what is largely a hospital-employed environment. Our area is largely dominated by 3 very large healthcare systems. The majority of physicians here, especially cardiologists, are hospital-employed. But by providing personalized patient-centric care at a fraction of the cost, we have been able to grow exponentially. As a leader in the outpatient revascularization market in the Tulsa area, our facility is able to be used as a training site and place of exposure for other physicians. There is an opportunity for hands-on training, procedural observation, where other physicians can be exposed to radial-pedal access site techniques and equipment, atherectomy devices, enhance their peripheral vascular intervention skill set, or just to familiarize themselves with an outpatient lab. I would like to welcome any of my colleagues who are interested in touring the facility or learning more. Please feel free to email me, call me, and we'll schedule you a site visit or course if requested.
That's awfully kind of you. So, Dr. Comstock, how did you come about selecting the suppliers you've used to operate your center?
That's a good question, Tim, and it took a lot of thought. So personally, the underlying principle I use when selecting products, suppliers, consultants, etc. for my practice really relies on the answer to 2 fundamental questions. Number 1, is it good for the patient? Number 2, is it good for the practice? Good for the patient. Is a device or technique proven to be safe, reliable, possess equivalent or superior outcomes compared to their competitors? The data really drives this decision here. I'm a huge proponent of intravascular ultrasound, also known as IVUS. IVUS improves appropriate vessel sizing, stent apposition, expansion, decreases incidence of stent malapposition, underexpansion, and acute stent thrombosis, and can also guide atherectomy treatment decisions. Atherectomy enhances plaque removal and debulking, improves outcomes with balloon angioplasty, and improves stent apposition and expansion. Another example would be the Cordis Smart Stent, which has superior 5-year patency rates compared to similar products. I routinely use radial or pedal access, vascular compression, and vascular closure devices. In short, the techniques and products we use for our procedures are proven to be good for the patient. This brings us to good for the practice. Will the practice have the opportunity to grow and provide a higher level of care as a result of the partnership or consulting arrangement? We have chosen to associate and partner with Philips, Arise Vascular, Cardinal Health, and their subdivision Cordis. We have partnered with Philips to provide us with all of our imaging acquisition needs, from our procedural C-arm, our diagnostic ultrasound, which can do echocardiography, vascular imaging, our stress testing systems, and procedural-related invasive tools such as intravascular ultrasound, laser atherectomy, drug-coated balloon angioplasty, etc. We are the only fully integrated Philips practice in the region. The Philips Cadence programs gives physicians, even solo practitioners like myself, access to world-class equipment at a very affordable price. They provide a single vendor and financing solution for imaging acquisition and hemodynamic equipment. In some instances, they may also help finance the cost of the OBL or ASC build-out. Arise Vascular has been an indispensable asset to our team. Through their operations oversight, they have successfully helped us navigate the regulatory and billing aspects of an OBL, and they will continue to be invaluable as we transition to an ASC-OBL hybrid. They consistently go above and beyond with assisting in staff training, policies and procedures, price negotiations, etc. I don't have enough good things to say about them. Cardinal Health and their subdivision Cordis have been able to provide us with cost-effective products and supplies we need to run a robust and efficient practice. Cardinal Health is able to provide a comprehensive single-source vendor for your ASC consumable products, from custom procedure packs to pharmacy supply chain needs. Cordis has proven to have products that have superior patency, such as the Smart Stent, and performance, such as the Minx vascular closure device. And they have been very responsive to market demands, providing competitive pricing, excellent case coverage, generous consignment. They have excellent data on the products that I utilize. Through our association with these three amazing companies, we have access to a wide network of support, industry connections, sharing of best practices, and a patient-centric and team-focused approach. This allows us to provide the best care to our patients possible. We would not be where we are today if it wasn't for our long-term commitment and partnership with Philips, Arise Vascular, and Cardinal Health. The most important benefit we have of partnering with these three companies is their commitment to your success as a physician.
Thank you. So in a moment, let's open it up to the audience for a few questions. But before we do, let me ask our faculty two final questions, along with some polling questions to give the audience an opportunity to provide input. So the first question is, what is the biggest barrier to implementing PCI in the ASC? If you could submit your response online, we'll give it about 10 seconds. Couple more seconds. All right. The results, the majority of it is around state regulation, but certainly some of the other factors influence around facility development and budget constraints. So Jared, can you share the decision process in evaluating whether you should open an OBL or an ASC, or for that matter, even a hybrid facility?
Yeah, great question, Tim. In fact, I spend most of my days these days helping physicians and groups evaluate this exact question. Which is better? Should I do an ASC, an OBL, or an ASC OBL hybrid? And we always say to let the financial forecasting data, the pro forma data, drive that decision. It really comes down to what types of procedures and what volumes you anticipate doing in the outpatient setting. If our main goal is to increase patient access to our high-value, high-quality care environment to as many patients as possible, then we must look at making the ASC or OBL as viable as possible. In order to set up this facility to be most viable, we must look at which procedures reimburse highest in which setting. As you guys all know, the PCI cases do not reimburse at all in the OBL setting, or at least not for Medicare. Additionally, most of the PAD procedures will reimburse more in an OBL setting as compared to an ASC setting. The venous stenting procedures, the rhythm management cases like pacemakers, loop recorders, etc., will all reimburse more in the ASC setting. So you can see why forecasting the types of case volume that you will be doing in the ASC or the OBL is so important. Next, we tend to talk about the cost or the capital outlay for an OBL versus an ASC. We think about our capital outlays in three buckets. One is the cost of the construction or the build out. Some folks call this tenant improvement or TI cost. The second bucket is the cost of the equipment. And then the third bucket is the line of credit or the carry cost associated with floating the facility until it's cash flow positive, or at least cash flowing in some way. On the construction cost side, OBLs typically cost around $125 per square foot to build out. And they're typically between 1,200 and 2,000 total square feet. For an ASC, our typical cost to build out is around $325 per square foot, and those are typically around 6,000 square foot minimum. The reason that an ASC costs so much more to build out as compared to an office-based cath lab is really due to your life safety requirements. An ASC will be Medicare licensed and oftentimes state licensed, and there are state regs as well as Medicare regs that you have to take into account. In an ASC setting, things like male and female locker rooms, piped-in med gas, a generator, HEPA filtration, HVAC systems, and many other items are needed in an ASC that you don't have to have in an office-based lab or an OBL. So for an OBL, we typically budget $250,000 for our build-out or the construction of the facility. And for an ASC, we typically budget anywhere from $1.5 to $2 million for the build-out. So just in that first bucket alone, you can see how much more capital is needed, how much more risk has to be taken to do an ASC. Also, let's look at the equipment cost. In an OBL, if you're only doing the PAD cases, then oftentimes a C-arm, a mobile C-arm will suffice with a radiolucent table, relatively inexpensive setup. In an ASC that wants to do PCI procedures, a large fixed-based imaging system is typically required. So we typically budget $400,000 for the cost to equip the OBL and about $1.5 million for the cost to equip the ASC. So again, a much larger cost outlay just in that second bucket. And then lastly is the working capital or line of credit funds that are needed to operate the facility into your cash flow positive. They're much higher in an ASC setting just because your carry costs are going to be higher. Your overhead is higher in an ASC versus the OBL. In the ASC setting, you must have a DON, an administrator, a quality committee, a credentialing committee, pharmacy license. There's a survey process to go through. And just the time to get your license can oftentimes be 3 to 6 months. And you must operate that and use those line of credit funds to fund those operational losses until you're positive. So for an OBL, we typically budget $200,000 for working capital, sometimes more. And for an ASC, it's anywhere from $500,000 plus. So again, that third bucket being higher as well. Next, let's walk through a couple of different case scenarios. So if you project to do mostly PAD procedures and only a small amount of PCI is expected, let's say 90% PAD and 10% PCI, then oftentimes the facility only needs to operate a minimal amount of time as an ASC to be able to capture that PCI business. In this example, it probably makes better sense to be an OBL only and not an ASC and just lose out on that 10% PCI business. If you anticipate an equal number of PCI procedures and PAD procedures, let's say 50-50, then most of the time the ASC OBL hybrid will make sense. And then lastly, I'll use a real life example. I was just helping a physician in the Midwest, a single cardiologist, evaluate if an OBL or ASC hybrid would make the most sense for him. He performs roughly 400 PAD procedures and roughly 500 PCI procedures per year. We then anticipated for him, as well as my guys, about 20% of those PCI cases could safely move to the ASC or same-day discharge setting. So this means for him about 100 PCI procedures annually and about 400 PAD. In this example, the ASC OBL hybrid did not make sense for him, and he chose to do the OBL only this year and perhaps move to an ASC setting sometime in the future.
Thanks, Jared. I think that's what, like you said, a lot of people are struggling with is how do you make that decision and what's the science or the numbers to it. So let's go to our second polling question. What do you feel the COVID-19 pandemic impact in your market will be on the PCI and the ASC market? If you could select one of those answers, either accelerate, no impact, decelerate, delay, or other. And again, we'll give it about 10 seconds. About 2 more seconds. All right, and here are the results. Well, the majority of folks think it's going to accelerate, so that certainly would be a positive thing if that were to occur. Jared, I know you already talked about this, but Dr. Comstock, from a clinical perspective, how do you see the current COVID pandemic influencing the growth of the OBL ASC market?
So, Tim, the COVID-19 and shelter-in-place orders have left a lot of patients feeling very vulnerable and unsafe going to the hospital or seeking medical care. There's an estimated 40% reduction of admissions for myocardial infarction across the country, and U.S. emergency rooms are seeing a 40 to 50% reduction in visits. As a result of the current pandemic, associated social distancing, shelter-in-place, etc., patients are feeling less safe and less comfortable in the hospital setting. As clinicians, we have all encountered this with our patients, their hesitancy to seek care, reluctance to go to the hospital, or even be seen in the clinic. As a result of the fear of the hospital, an OBL or ASC that does aggressive, consistent COVID-19 pre-procedure testing or pre-screening in compliance with CDC guidelines may be able to re-attract a large volume of patients that aren't comfortable in the hospital setting. I anticipate that OBLs and ASCs, as they begin to publicize and market their formal policies and procedures for COVID-19 pre-procedure testing or pre-screening, that they will be able to see a rebounding of procedural volume with an exponential increase over time. In my mind, the key to this really relies on increasing the public's awareness of your pre-procedure testing and a commitment to COVID-19 free ASC.
Thank you. Now we'll turn it over to Angie for some questions from the audience.
Thank you, Tim, Jared, and Dr. Comstock for that fantastic presentation. We'll now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we will try to get through as many questions as we have time for, which we have a lot of great ones coming in, so we'll try to get to as many as we can. One of the first ones we have here is directed to Dr. Comstock. So Dr. Comstock, what was your biggest challenge in opening your ASC?
Quite honestly, is finding the appropriate staff. You're only as good as the people that you work with. And so you need an A+ team if you want to be an A+ facility. I think we can all relate to that. You see many hospital facilities that have very slow turnover times. Cath lab staff are used to having, half an hour to an hour downtime between procedures. They're not used to a small, busy office-based practice. And so finding self-motivated employees is actually one of the most challenging things.
Yeah, that makes a lot of sense. And we have an audience member who says they've heard a lot of concerns about safety measures from staff for these procedures from an emergency standpoint specifically. So how have you addressed this in the office-based lab and ASC hybrid? And Dr. Comstock, we're staying with you for that question.
Sure. So safety is very important. So most importantly, you start with the proper patient selection. It's got to be the right patient and the right procedure. If those don't meet up, then you take them to the hospital. And that can eliminate 99% of your problems right there. It's getting over-aggressive with the wrong patient or the wrong procedure in the outpatient setting. Heavily calcified iliac arteries, do those in the hospital. Don't risk an intra-abdominal perf in an outpatient lab. That's kind of basic stuff, but a little more detailed. We have fully stocked crash carts, defibrillators. We're prepared for, cardiopulmonary resuscitation, anything of that nature. We also utilize an iStat and do routine ACT screening during all of our interventions to make sure the ACT level is therapeutic. But also we have transfer arrangements with other local hospitals that I'm affiliated with. And so between all of that, we also have, with our partnership through ARISE, we've developed a lot of policies and procedures that help keep our patients safe, help our staff stay safe and educated in best practices. And this allows us to function very efficiently, very fluidly. And in the event that an emergency were to arise, we would know how to handle it based on previous training, certifications, dry runs, and if needed, to transfer the patient.
Absolutely. Thank you for that clarity. So we have another question. Someone wants to get at this from an interventional cardiology perspective, and they're hoping that you can provide guidance on different partnerships in ASCs. So a hospital partnership versus ARISE Vascular versus totally owned by the interventional cardiologist. So Jared, could you address that question and provide that guidance on how different partnerships could look in ASCs?
Yes. I think I would first have to ask, what are your needs? Because each one of the partnership options that you bring up bring different, I would say, value propositions. So if you own it by yourself, you're going to go at it alone. All the risk is going to be your own. Do you have the capital wherewithal, the credit worthiness to be able to do that from an economic perspective? Do you have the skill set to financially forecast appropriately and budget? Do you have the know-how within your organization to be able to get it going, set it up, operate it long term? I think from a hospital partnership point of view, typically a hospital wants to own 51%. I mean, that's not always the case, I don't think, but at least what we see typically is 51%. For that 51%, oftentimes they can bring managed care contract leverage. They can extend out their hospital-based contracts perhaps to your independent ASC. That would be a value prop that I think a hospital could bring. At 51% ownership, perhaps the hospital could help you guarantee debt and bring some of their capital resources. So sort of look at what they bring, but that's going to be bringing that in exchange of what? That's giving up quite a bit of equity to your partner. I think in companies like my own, we are happy owning a smaller percentage, oftentimes 20% in a minority ownership position. And for that, we still bring corporate guarantees, some risk mitigation strategies. We're your corporate partner along with you. Yes, we then also manage, bill, and collect, but we have a vested interest in the success of the facility from a bottom line perspective, not just top line point of view. So I think risk sharing is probably one of the nice things that a company like mine brings, but also the engagement of having a partner to not go at it alone, perhaps. And then again, just the fact that most of the independent management companies tend to take a smaller ownership piece as compared to a hospital partnership.
Excellent. That's an awesome and super helpful oversight there, or overview, I mean. We actually would like to stay with you for this next question here, and we'll also have Dr. Comstock weigh in. But beginning with you, Jared, what do you suggest for a solo interventional cardiologist with an office-based lab who wants to do PCI?
Great question, and again, oftentimes what we're getting calls about. And so we always want to start with, what does your current lab look like? Can it be easily converted to an ASC? If it's inside of let's say a normal office structure, oftentimes that's not a large enough space to be easily converted. Oftentimes there's not a fire sprinkler system or the other life safety requirement needs that are needed to convert. And then if you are going to convert an existing facility or OBL to an ASC, Are we going to close it down? Can you sustain the close down of that facility and the financial impact of that? So we've got to sort of evaluate what the conversion options are. If the option is not to convert, but rather to start a new one, then I'm sort of back to my last comment, which is I would let the financial data drive that. Do you have enough business by adding the ASC to warrant that increased capital structure and increased overhead? Or is it better to just keep with your OBL for now, save up some cash, and when you have the financial wherewithal, then do an ASC, perhaps with other independent cardiologists?
Great. And Dr. Comstock, do you have anything to weigh in on that question?
Well, I think Jared covered it pretty well from a standpoint. Personally, like I said, I personally was only able to afford the OBL build out as an independent private practice solo guy. Your group dynamic may change, but as a private practice or solo practice physician, it really comes down to what you can afford and what your case volume is. It really is just data drives the decision there and economics. So for me, personally, an OBL was the preferred step to outpatient revascularization and independent practice. In the future, as volumes continue to increase and we develop increasing partnerships with other physicians, transitioning to the OBL hybrid ASC hybrid model is in the works.
Good to know. Great. And we actually have a lot more rolling in here, questions from the audience. So I'm going to field one back to you, Jared, regarding equipment. One audience member wants to know what specific equipment is needed, like a CR, a surgical bed. What else would you say needs to be installed here?
So I'm going to assume that it's a ASC related question, and it's a good question because in order to do the PCI procedures, they're pretty difficult to do on a mobile C-arm. We see some folks doing it with a flat detector mobile C-arm, but the imaging capabilities are really limited. So it's going to be a fixed base system, and you can have both a ceiling mount and a floor mount option on those. But that's going to be your most costly piece of equipment. And with that comes the bed or comes the floating table that's radiolucent. And so that whole setup is anywhere between, I'd say on the lowest used refurbished market end, probably $500,000 on up to over $1 million. But you have to also have a hemodynamic monitoring system, intravascular ultrasound system. If you're going to do laser or regular atherectomy, you must have the atherectomy machine. And those are just to name a few. We have a comprehensive list of equipment that's needed, but that's kind of the top, I'd say top 3 or 4.
Awesome. That's super helpful. And kind of as a follow-up to that question, so would an ASC need to have a control room built into it in order to do cardiac cases?
We see it both ways. I think it's more of a preference thing. Our personal preference is to have a separate control room. That way the other staff are not exposed to radiation. And they can, you can also we tend to do a lot of training. And for non-physician training, let's just say like allied health or maybe a student, it's nice to have them be able to watch the procedure from the control room. But then again, we also see some labs. In fact, one of my labs in Louisiana has the control room in the room. So the room must be bigger. And then you must consider what sort of radiation safety blocking mechanisms are you going to use, a rolling shield, or sort of what are you going to use from that standpoint. But we see it both ways. I would say that our preference is to have the control room outside of the ASC operating room.
Gotcha. That makes sense. Thank you for answering that one. And we're going to kind of shift gears here and go to a more regulatory topic. One of the audience members would like to know, what hurdles do you see in states that have certificate of need laws and starting cardiovascular ASCs in those states? And we'll field this question first to Jared, but anyone who'd like to weigh in can jump in after that.
Yeah, so this is a rapidly evolving question, and so certainly state by state it's different. I was just on a call last week, I believe, with a group out of Mississippi where their CON laws are being changed, and they hear that they're going to let single specialty cardiovascular ASCs fit within the CON law as long as there's a hospital partner involved. And so what I would say is that certainly the hospitals are, lobbying at a national and a local level to make sure that the hospitals aren't excluded from that conversation in the CON states. But I would say it's rapidly changing. But to his point of the question is that if Medicare wants adoption of PCI in the ASC setting, then the federal government has to do something to put some pressure on the local states to allow CON waivers to be allowed to have ASC and be able to do PCI in the ASC setting.
Absolutely. And Dr. Comstock, would you like to weigh in on that question at all?
Could you give me a little bit more detail of what you're looking for from a clinical perspective?
Just what you're seeing from being on the clinical perspective and being actually on the front lines of things. Do you think this will affect your practice? And have you experienced any challenges with regards to certificate of need laws?
Luckily, he's in a state. Yeah, he's in a state where he's not going to have to worry about that. But certainly in other states in the U.S. where the CON laws are enacted, you're going to have to see some local adoption at the state level to allow waivers to happen for the cardiovascular ASCs. But luckily, in Dr. Comstock's market, his state does not have a CON law against ASCs.
And Jared, I'd comment that Scott Becker does a great job of monitoring all those CONs. So I'd stay close to Becker's ASC review for updates on that, because I think it's posted frequently.
That's where we get our information is from Scott's publications.
Awesome. Yeah, thank you for plugging Becker's. We do have a lot of coverage on certificate of need laws, so appreciate your insight there and referring people back to us. And we have another question that's come in here. What does the skill level and experience for nursing staff look like for PCI and PAD procedures? And do you recommend having cath lab experienced staff? So if someone would like to jump in for that question, please feel free.
Sure. Yes, I strongly recommend having cath lab experienced staff. It's very difficult to take a hammer and chisel ortho-trained scrub tech and get them comfortable navigating a 1/1400th of an inch wire down a coronary artery. It's a very different type of procedure. And so I think also we do a different type of monitoring when you're doing PCI. You're doing real-time invasive hemodynamic monitoring, which is, coronary flow pressure is very critical during successful procedures and to prevent patient harm. And you need staff that's appropriately trained to recognize that and to be aware of perfusion pressure, rhythm disturbances, things of that nature. So yes, without a doubt, I would recommend cath lab trained circulating staff and scrub techs.
Excellent. Thank you so much for jumping in on that one. And it looks like we're coming up to the end of our time today. So I wanted to pose a question back to Tim, Jared, and Dr. Comstock. Do you have any final thoughts that you wanted to get in before the end of the hour?
I just want to thank you all for the time, and Dr. Comstock and Jared for sharing their knowledge. And certainly this is a dynamic market, that things are evolving quickly, as Jared referred to, from a legislative standpoint, but from a clinical and regulatory standpoint as well. So we'll just hopefully provide more opportunities down the road.
And I'd like
Thank you for having us.
There's a lot of questions still remain to be answered, and I think Jared and I both would be available to answer them via phone call or text message, email, whatever. If you would be able to provide them with that information, we'd appreciate it.
Absolutely. So thank you all for your time today, Tim, Jared, and Dr. Comstock. Thank you for your excellent presentation, and thank you to Cardinal Health for sponsoring today's webinar. We want to let you all know that the slide deck will be available after the webinar for you to access, and we hope you enjoy the rest of your day, and we look forward to having you join us for future webinars.